the other thing you can do. So the chat function will be available, and I'll be asking some questions by chat. So this is a talk about hypertension, and we've got 2 hours. I'll talk for about 45, 50 minutes, and then we'll maybe have a 10-minute break, and then we'll come back, just that you'll be getting pretty exhausted sitting looking at these things all day. Okay. So the key thing about hypertension, actually, and here's the first little curveball, is there's no such thing as hypertension. And I'm going to show you that in a little while. But before I do that, I just want to tell you about the Goodfellow unit, because I'm the head of Department of General Practice and Primary Health Care, and I'm also the director of the Goodfellow unit. If you don't belong to the Goodfellow unit, you probably should. We've got lots of good stuff. You can see here, we've got webinars, films, and everything's free, basically. You might want to sign up to my Goodfellow Gems, and there's one there about treating down to 120, which we're going to be talking about a bit today. No increase in concern about falling. And another one there you can see down the bottom, great aspirin decision tool. We're going to be talking about that again today as well. These are our webinars. We just had one on managing common neurological conundrums. We had 700 people turn up to that. We sometimes have 1,100 people, so I suggest you join the crowd. We had a webinar, the Goodfellow Webinar Marathon, on March the 28th. We had 1,100 people sign up for that. So webinars are great ways to learn. And we have podcasts as well. So if you're commuting, which most of you won't be at the moment, you can listen to them in the car or on the bus. So this is goodfellowunit.org, so sign up. Everything's free there. So back to hypertension. So this is a Yanomamo Indian, and he's the poster child of hypertension, because this group of indigenous people live in the back blocks of Venezuela and Brazil, and they still live an indigenous life. Now, what's significant about these people is their average blood pressure is 95/60 for an adult. Now, there'll only be a few of you in the audience. Small young females would be probably the only ones in the audience to have a blood pressure like that. And their blood pressure doesn't go up with age. Those of you in the room, depending on your age, if you're in your 50s or 60s, your blood pressure will be higher than it was when you're in your 20s. If you're in your 20s, I'm sorry, the bad news is you're going to have a higher blood pressure in your 50s and 60s. So these people's blood pressure doesn't go up with age, and it's thought that it's due to the fact they eat virtually no salt. Their sodium intake is 1 millimole a day. Your average sodium intake will be about 150. If you eat an Asian diet, it'll be up to 300 millimoles of sodium a day. And we don't need that extra sodium. And the way I think about it is we have all the sodium in our system, and to get rid of it, the kidneys have to put the blood pressure out to squeeze it out into our bladders to get rid of all that salt. So one way of reducing blood pressure can be to lower sodium, but it's not very popular because we all love our sodium. These people don't live long lives because it's a fairly dangerous environment. They fight a lot with other tribes. It's dangerous living in the jungle. You cut yourself, you get infected, you fall out of trees. So, but those who do live into their 50s and 60s don't have their blood pressure going up, and that's thought to be due to that. So we've got a good crowd today. We've got 76. So we've got postgraduate nurses here, and 4th, 5th, and 6th year medical students, or as we call them, doctors in training. So we've got quite a bit of interdisciplinary discussion today. So I'm expecting lots of questions. One of the things I love about teaching nurses is you ask lots of questions. So I hope to get lots of questions today. Okay, so this is me. I've been a GP in the department since 1991 and a GP in Manurewa since 1991. Head of department at the moment. I lived in rural Canada and spent a year at McMaster University where evidence-based practice was starting. I'm the editor of 3 Cochrane reviews And I'm interested in practical research, stuff you can do tomorrow. So in terms of hypertension epidemiology, a bit like the COVID virus, we're interested in time, place, and person, when people get this, where they're living, and who they are, and also about the frequency of events, how often these things happen. And of course, with hypertension, it tends to come and stay unless there's major lifestyle things. And we know this from cohort studies. We know what the risk factors are. And we know that by treating hypertension, we can make a big difference. The first randomized trial on antihypertensive medication was done in 1967 in the Veterans Administration. And these were World War II veterans, maybe some World War I ones as well. And they had enormous cardiovascular risk. They were smokers, they were overweight, they had terrible cholesterol, and they, within 18 months, the numbers needed to treat were 6 to prevent something terrible happening, like a heart attack, stroke, descending aorta. So we know that treating blood pressure is hugely beneficial to people when they've got a high cardiovascular risk. And I'm going to show you at low cardiovascular risk, the benefits are pretty feeble. So this is hypertension. And I guess I would say to you, and going along the bottom there, we've got blood pressure level. We've got age going up on the right-hand side. On the left, we've got ischemic heart disease mortality. This is based on about 1 million patients. And you'll note the ischemic heart disease mortality on the y-axis going up over here is logarithmic. So up here, we've got 256 times the risk of a younger person with a low blood pressure. And at every level of blood pressure, the risk goes up. But you can see here, actually, age is the biggest risk factor for ischemic heart disease, not so much blood pressure. And there's no one place there where you can say, that's hypertension. Now, we do set thresholds. We set thresholds at 160/90 for low-risk people, 140/90 for high-risk people in terms of lowering their blood pressure. But you can see here, there really isn't anywhere where you'd say, and Rod Jackson actually says, if you take a line down here from the left-hand side to the right-hand side, that line would sort of say hypertension. So here's the traditional level of 160/90 or 160. We don't really worry about the diastolic at the moment. When I was at medical school, we were taught to only worry about the diastolic. It may be coming back into fashion in the next few years. Those of you who have been around a while will realize how much healthcare changes with time. And half of what you're learning today will be different, not just in hypertension. Hopefully we've got that a bit more sus, because there actually has been a lot of research about hypertension. It's one topic in healthcare we know a lot about. And that's the more traditional lower blood level at which we try and get blood pressure down to. But let me just show you this. So if we take a female with a typical New Zealand cholesterol, which is about 5.7, that's the New Zealand average, an HDL of 1.4, she's non-smoker, no other risk. If we just look at her blood pressure and she's 45, the numbers needed to treat to prevent an ischemic heart disease event are 303. If the same woman, by the time she gets to 65 and her blood pressure stays the same and everything else stays the same, the numbers needed to treat are 90. By the time you get that woman gets to 80, the numbers needed to treat are 37. So you can see there, it's not blood pressure that's the risk for a woman, it's her age. And of course, she can't do anything about her age, but you can, as a healthcare professional, you would want her to lower her blood pressure unless she's getting postural hypotension. And I think we have to keep a balance on that. You can see the risk with people up in their 80s to 90s is enormous. For a man, the numbers need, a high-risk man, the numbers need to treat and get down as low as 6. And there's not much in healthcare you're going to do with the numbers needed to treat of 6. What that means is for every 37 people you treat, only one of them will get a benefit. The other 36 won't. Now, we consider that quite a reasonable numbers needed to treat. We probably would accept that's not unreasonable there, but I think none of us would get very excited about a numbers needed to treat of 303. Although one person, age 45, and of course, if it's a patient on your watch who gets it and you didn't treat it, you're going to feel bad about it. But I don't think many 45-year-olds would be too excited if you said, well, for every 303 people like you, only one of you is going to get a benefit. Okay, so here's the Heart Foundation guidelines. So we suggest patients who've got a 5-year risk of 15% or higher, we treat their CVD risk with statins, irrespective of their LDL level. And really, from the point of primary care, the only game in town is statins. There's really nothing else you would bother using in primary care. Perhaps in your cardiology lipids clinic, you might use some other things, but statins are the most effective treatment that are readily available at the moment. There's some antibody drugs which are coming down the pike, which are even more effective, but they're not available here. And then we might consider statins with a 5-year risk between 5 and 15%. And that is a negotiation. And we now, I've just checked with Devika in our clinic, she's our head nurse, and New Zealand, we are using the new risk tables, and I'll show you where you can look those up. So this is the LDL target. So if they're between 5 and 15%, which would be a good number of people who are watching this, you just want a 40% reduction of LDL. And if it's greater than 15%, you like it less than 1.8. Now that's somebody who's had a heart attack or a stroke. Most people at 15% will have had a heart attack or stroke. You need to have a lot of risk factors to get up there. That 40% there is a consensus figure. In other words, it's been made up by a group of experts. And I hope you realize that in healthcare, groups of experts make up a lot of things. Well-meaning, there's no science behind that 40%. There is some science behind the 1.8. If you get LDL cholesterol down to 1.8, you can reverse the atherosclerotic process. Okay, when it comes to blood pressure, 160 over 100 we would treat irrespective of other risk factors. Or if the CVD risk is 5 to 15%, we might consider 140/90. So that's getting pretty low to what we have done. And if you're looking at electronic blood pressure machines at home, it might be as low as 150. So what we get in the office is a bit higher than what people get at home. That may be a white coat effect. It may be a function of the electronic machines that people use. The targets for blood pressure in the office, we like to get it to 130/90. If at home or on 24-hour blood pressure monitoring, 125/85. And of course, that's not that easy to hit because blood pressure is going up and down all day. And I will show you some examples of that. If you've got a very high risk person, you might want to get this down to 120, depending, you don't want them falling over and breaking a hip. But most of our patients in primary care, they do have falls when they get older, but we don't want them having strokes. Aspirin's an interesting one, and we'll look at aspirin later on. For primary prevention, it's barely worth doing. Numbers need to treat it like 100. So if you're below 70 and you have a 5-year risk greater than 15%, you may benefit from aspirin. Greater than 70, the evidence is insufficient, and I'm going to show you a calculator, which we'll use later on, about how you can individualize that for a patient. Aspirin for primary prevention in those with a 5-year risk less than 15% is not recommend. I would suggest you do the risk using the risk calculator, and the risk calculator is here. And I'll be sending out the slides for this at the end of the talk today. And I'll be making this into a YouTube video, or actually, Gigi will have to send it to me to make a YouTube video.
We could do it, Bruce, but yeah, both ways is fine with me.
Okay, yeah, no, I can, if you can just send the file to me. Then
And you'll do a YouTube. Okay.
Yeah.
Yep.
One of the skills I've learned in the COVID shutdown videos. It's been quite an exciting good time. Okay, so this is the calculator. It's done by Vanessa Selak, who works in the School of Population Health. She's a public health physician. So this is the high point for being a public health person these days. They've never been so popular with the, and I bought myself an Ashley Bloomfield t-shirt, which I shall wear for Public Health Week when we do that for the 50th students. The good thing about that is $20 go to the Women's Refuge, and you get a chance to see just a wonderful bit of leadership there, which I'm sure you'll all agree with. So if somebody's seeing what the numbers are today, I'd be interested to know what the new cases were, if somebody could pop that into the chat. Where do you get them from? It's from a Dunedin company. I can't remember what it was, but flick me an email if you, and I can find it. 5 new cases, okay. So we're still up there a little bit, but I think the modelers are suggesting it'll drop to 0 on May the 4th. 5 new, 2 confirmed, 3 suspected. Okay, thank you, folks, thank you. Okay, so there's a special group of people. People who have serious mental health problems like schizophrenia and some people with bipolar disorder have a greater relative risk of cardiovascular disease than the rest of the population. They die 20 to 40 years earlier than people who don't have mental health problems. And the new Heart Foundation guidelines suggest we should do a risk assessment on them. But the problem is, when you meet people with serious mental illness, it's likely to be a 25-year-old male who's on antipsychotic medication. He's getting injections that will mess up his lipids, or he's taking olanzapine to control his psychosis, but that will be messing up his metabolic things. So he'll be getting diabetes. We had a 28-year-old man with schizophrenia have a heart attack or die. Unfortunately, he needed to be on olanzapine, and he knew that because he couldn't work without it. He actually worked as an accountant in a sheltered accountancy firm. That's very unusual for someone with schizophrenia. So the problem with a young person with a serious mental illness is age is the big risk factor for heart disease. So you have to look at their risk profile and probably add 20 years because their lipids aren't going to be that bad. They've probably not got diabetes yet. You've really got to put 20 or 30 years on them and then start prescribing medication, such as a statin. A statin may be quite a good idea. The problem with a 25-year-old schizophrenic, he's likely to be smoking and not looking after his health, probably living in a not very satisfactory environment. So it's not easy having a serious mental illness, even in a relatively caring environment like New Zealand. Also, somebody with congestive heart failure is automatically at high risk. So that's a group you might want to get their lipids down and keep their blood pressure under control. Atrial fibrillation is now considered a risk factor for cardiovascular disease. Okay, so that's the risk tables. So dimensions of time. So remember we talked about time, place, and person. So we're interested in the time of day, the time of year, and the time in the century, and over time, if we follow people through to the future. As I said to you before, your blood pressure now will be higher in 10 to 20 years' time, whatever your current age, if nothing's done about it. Lifestyle. In terms of time of day, blood pressure goes up in the morning and comes down at night time. In terms of winter, if you're an elderly person, there's a 15mm difference between winter and summer. And if we look at the time of the century, in the 1900s, people presented with hypertension, with a stroke, heart failure, or kidney failure, they would have had enormous blood pressure levels. You may not know that the Treaty of Waitangi was delayed a day because Governor Hobson had a stroke and he wasn't well enough on the 5th of February, so it was signed on the 6th. And he would have been eating salted meat and probably would have had a very high blood pressure. Of course, well, we weren't measuring blood pressures back there, but one of the reasons for a short life expectancy. And Rod Jackson points out that the advent of the refrigerator in New Zealand society, and my parents got a refrigerator in the 1950s, was that stroke dropped in New Zealand because people didn't have to eat salted food. So let's just look. So that's a 24-hour blood pressure monitor. And you can see there, it goes up in the morning and then down at night time. And what's interesting over here is that in some people, their blood pressure doesn't drop very much in the early hours of the morning. And those people are at more risk of high blood pressure. And it's probably one of the reasons we should use longer acting drugs to control blood pressure. It may be the reason why taking blood pressure pills at nighttime actually has better cardiovascular benefits than if you take it in the morning. I'll come back to that. So in winter, if you look at people in placebo groups, on studies, there's a 15mm difference. Got a question from Hannah there. Do you want to unmute Hannah and ask your question?
That was just a mistake. Sorry, Bruce, I don't have a question.
Okay. I'll take it as a thumbs up. Okay, thanks, Hannah. Okay, but the other interesting thing that's happening is blood pressure is falling in spite of the fact that we're all getting bigger. And this has been studied in college students. So this is in 20-year-olds. So it's not due to treatment. Very few 20-year-olds are treated. And this may be the Barker hypothesis. So if you're young today, if you're in your 20s, your mother would have had better prenatal care than your grandmother did, than your great-grandmother did. And good prenatal care reduces your risk of cardiovascular disease as you grow up. So it may be a function of that. Rod Jackson thinks it's due to dietary fat. We're all eating better dietary fat. We're not eating so much butter, thanks to the YouTube video on him, but we're eating more liquid fats, which are better for you. Fats that are liquid at room temperature are the best ones for you. And so things like olive oil are quite good for blood pressure, he thinks. But of course, that's making us fatter, but it's reducing our blood pressure. So it's a bit of a double-edged sword. So here's blood pressure in New Zealand. So this is for men, and it keeps coming down, basically. And that's for women in New Zealand. And that's a bit of an international trend. So although our cardiovascular risk may be going up, there is this countervailing effect of blood pressure going down, which will reduce cardiovascular risk. Coming back to the indigenous people, the Yanomamo Indians, they have a low salt, low alcohol, high exercise, low fat diet. They're also quite small, so they'd be the size of a young teenager. You don't get very many 6-foot high Yanomamos. They're fairly small. And I say they do fight a lot. The original anthropologists thought they fought over food, but actually the men fight over women. They like having multiple wives, and so they fight for the company of women. So it's a fairly violent society, interestingly. So that's, and I'm sure they wonder why American hypertension researchers come and do 24-hour urines on them. They must think we're if you ever saw that film, The Gods Must Be Crazy, when the bottle of Coca-Cola gets thrown out of an airplane onto an African bushman, I'm sure they must think the Americans must be crazy coming down and checking their urine for 24 hours. It's a bit of a hassle doing a urine for 24 hours because you have to walk around with big bottles, or leave a big bottle in the toilet so you can capture all your urine for 24 hours. So in terms of causes of blood pressure, 95% of it is essential hypertension. There are a couple of other causes. One is kidney disease. And essentially, as an elderly person in our society, by the time you're 70, you're down to 50% kidney function. Now, that doesn't show up in your blood tests. Your blood tests still look normal for most 70-year-olds. There are the 3 adrenal hormones, aldosterone, adrenaline, and cortisone. If you have chemicals, hormone secreting tumors in the adrenal gland, all three of those can cause problems in terms of blood pressure. And then there's a physical cause called a coarctation of the aorta. That's where you have a blockage in the aorta, which is the ductus arteriosus, which didn't close properly when you were born. And this means that your heart's pumping against a narrow hole, lumen in the aorta, and the blood pressure in the head and arms is very high, but normal or low in the legs. Usually shows up in people in their 20s. I had a friend at university who had it in his 20s, and I had one patient once who had it, and she got surgery for it. The pressure can get so high that when you do a chest X-ray on these people, you can see little dings on their ribs. That actually the blood pressure going around into the ribs can put it up. So that's, and the way you check for that is with a new patient with hypertension, you feel their pulse with one hand and you check their femoral artery with the other. Now, I would advise you when you're sticking your hand in a patient's groin to check their blood pressure, you explain what you're doing, or you might end up getting in front of the nursing or medical council. So you explain to people, I'm just checking, you haven't got any blockage. And if you feel the pulse hit both fingers at the same time, they don't have coarctation. You'll be lucky if you ever see one in your career, but it's not something to miss. And it'd be the sort of thing you'd want to do in a person under the age of 30. So somebody came in with high blood pressure, which would be high in their arms, that would be the person you'd want to check. So anybody with hypertension under the age of 40, I would say. For women, sometimes that can be due to a renal artery stenosis. So hypertension is a disease of older people. If you start seeing it in younger people, you have to think about some of these secondary causes much more so. Although obviously as your kidneys start to fail as you get older, that can cause high blood pressure. So there's coarctation of the aorta. Sometimes I have heard a renal bruit on a patient, but I knew the bruit was there. You might want to check the pulse for thyroid or arrhythmias, but that won't necessarily relate to blood pressure. We do height and weight to get a body mass index, or a waist circumference is actually even better. If you're going to do a waist circumference, ask the patient to put their finger on the tape measure and get them to turn around. That way you don't have to put your arms around the patients, which one of my colleagues rather hazardously fell into the belly of one of her female patients and put lipstick all over her shirt. Both of them had a good laugh about it, but if you want to be a smooth practitioner, just put the tape measure on the patient's belly and get them to turn. It's a more sophisticated way of doing it. Whether you bother looking into the optic fundi for retinal damage is a moot point. Many years ago, I met Fred Hollows, and I said to him, he was an eye surgeon. You will have heard of the Fred Hollows Foundation. And I said, have you ever seen somebody with level 3 optic changes? And he said, yes, I did 40 years ago when I was working in Nicaragua. So you'll hardly ever, and you're just going to lower the blood pressure anyway. So if they don't have diabetes, I wouldn't fluff around with fundi. You're only seeing 4 degrees of the retina anyway. The ophthalmologists have gear where they can see 220 degrees. So with the ophthalmoscopes we have in the office are not very good at seeing the optic fundi. Or there are those reverse ones which you can see a bit better. You'd want to listen to the heart and lungs to see if the patient had any murmurs or basal creps. You might think they have heart failure. Check the pulse, and you might want to check the peripheral pulses. If you can't find peripheral pulses, they likely have peripheral vascular disease. If they're usually you'll find that in smokers. It's very unusual to find peripheral vascular disease in someone who's not a smoker or got diabetes. So you'd have other reasons for checking the peripheral pulses. But time spent on looking at the optic fundi is going to be a waste of time. And most of us aren't that good at looking at retinas anyway. you know, you need to be an ophthalmologist to be good at looking at retinas. In terms of investigations, we would do sodium, potassium. Now that's not, we can't measure sodium in the blood as a measure of body sodium, but we're looking for endocrine things. So if somebody's got a Cushing's or a Conn syndrome, then there'll be abnormalities in the sodium and potassium. We check the kidney for creatinine. You might want to check the urine for albumin and casts. You might want to do a full blood count looking for large red cells. So you're looking for a mean cell volume that's up, and you might want to do a GGT to look for heavy alcohol intake. So if somebody has a high mean cell volume, the cells are greater than 100 on the units the lab used, or the GGT is elevated, or both, then the patient may be, you need to ask about alcohol anyway. Alcohol's a question you must ask. So generally, if we find somebody with a high blood pressure, there's no hurry to treat it unless it's 220 on 120. But even then, you'd be surprised how many of those people live a very long, healthy life. I've got one lady who's been going about 25 years now. She's starting to get into a bit of trouble because of her diabetes, but she was a 220 on 120. She doesn't like taking medication, so it's a real problem. So you'd probably get somebody back on 2 or more occasions. And then you'd look at, and you'd start lifestyle things straight away, because most people can do something about their lifestyle. You'd get their alcohol intake down. So it's a bit sexist, but men are allowed 21 drinks a week and women 14 from a health point of view. And I often say to patients, look, I don't have a moral issue with alcohol, but if you're drinking a bottle of wine every day, that's not good for your health. It's not good for your sleep. It's not good for your mood. And it's not good for your wallet. You know, there's a whole lot of things. So get people to cut down their alcohol, increase their exercise, and reduce their sodium. We'll talk about sodium a little bit further downstream. So if we're going to start treatment, we would generally start with, if somebody's got a high enough blood pressure, I generally start with an angiotensin receptor blocker and hydrochlorothiazide. We have one combination here called losartan. You may know that Innovase Plus, silazepam plus hydrochlorothiazide, is going off the market, but I think you should stop using ACE inhibitors and move over to angiotensin receptor blockers. They're all funded by Pharmac now, and they're just as good as ACE inhibitors, and they don't have the cough. If you keep using ACE inhibitors, 20% of your patients will have a cough, and then you have to stop it and go on to something else. So if Pharmac funds thing, you don't have to do the rationing. That's all okay. We'd probably check the renal system, so creatinine and perhaps an albumin to creatinine ratio. That's a urine sample where you look at the amount of albumin and creatinine in the urine. If that's up, it's a predictor. It's quite an expensive test. It's about $25. And you might get the patient to stop taking NSAIDs, which can be very tricky because they're very good painkillers, but they can be a problem in terms of hypertension, but more so cardiovascular disease. They sort of can double your risk. Okay, so perhaps we look at a visit, we might do 3 blood pressures and do the average of the last 2 blood pressures. Of course, that's a bit tricky if somebody comes in with 180 on 105, and then 3 minutes later it's 160 on 105, and 3 minutes later it's 140 on 90. What do you make of that? In that case, you might want to get the patient to be doing blood pressure measures at home, and the blood pressure machines are about $100 to $150, and there is some advantage in getting them to do a home blood pressure. If a patient had a 250 on 130, I'd see them later in the day and consider treating immediately. If they've got cerebral signs, if they look like they've got they're going a bit loopy, then you'd want to send them to hospital. If they're not a bit loopy, they're cognitively okay, you would then probably give them something, start them in the office and see them later. That first situation I was describing might be white coat hypertension, and they may be the most relaxed person on earth, but coming in and seeing a doctor or a nurse is a stimulus that can put blood pressure up. So a lot of people say, well, I don't feel anxious coming to see you, but then they go home and their blood pressure is 20 or 30 millimeters lower when they go home. Okay, so now some of you will have seen this picture before. So the doctors in training have all seen this in second year, but this is a guide dog puppy I trained about 10 years ago. His name is Gnarly. This is the little break for you to have a break from all this talking. But when I saw this picture, which is a gorgeous picture and would make you want to have a puppy like that, absolutely gorgeous, he's looking a bit pensive, isn't he? How do you get the dog to sit still? So if you've not seen this picture before, just tell me. And the answer is not food. This is a Labrador. So how would you get the dog to sit still? So if anyone just wants to have a wee go at that. Somebody knows you spin the dog around. So I hope you're not cheating and you've not seen this before. That's true. You spin the dog around. So this is a vertiginous guide dog. How did you know that, Graham? Had you seen this picture before? Yep, we've got a confession there. Yeah, so you spin them around. Now, I love dogs, and some people feel that's cruel, but it is such a gorgeous picture with his little red coat on. So yeah, so that's now it's interesting. So this is a bit of a sad story. He went to Christchurch, and then something not nice happened to him. So, but he's still alive, and he now lives in Auckland. So I'll come back to that if you remind me before I finish. Okay, so I had a good fellow Jim a while ago, and it was about hypertension urgency or not so urgency. And they looked at a bunch of people whose blood pressures were 180 and 110. Now, if you're not used to looking at blood pressures, that's probably going to terrify you. But the people who stayed with their GPs actually did better than people who were sent to the hospital. It may have been because people were sent to the hospital because they had more things wrong with them, and the GPs hung on to the less severe ones. But actually the outcomes were pretty well the same. So blood pressure of 180 on 110 is not a reason to put somebody in an ambulance with sirens. It's you get them doing lifestyle things, get them exercising. Patients like exercising. So coming back to the 120 versus 140 target, there was the wonderful sprint trial recently. And in terms of when they looked at the 75-year-old group, 10.9% of them had an event when they had their blood pressure lowered to 120. And those who had their blood pressure left at 140 had 15.5%. So that's a numbers needed to treat of 32. Now that's an incredibly good numbers needed to treat because they're both active treatments. This is on top of the actual treating of the blood pressure down to 140 at least. This is in addition. And the death rates numbers needed to treat were 38. Now the only problem with this is that you have to give more pills to patients. Instead of 2 a day, probably 3 a day on average. And they will feel a bit lightheaded. Having said that, the group that went down to 120 had fewer serious falls. And I would speculate they had fewer serious falls because they were having fewer arrhythmias and fewer TIAs and perhaps fewer strokes. Now, we'll never know that because everyone wasn't examined, but there was actually fewer serious falls. So although people felt more lightheaded, and the other thing that happened in this study is that the more fragile group, now these aren't fragile as in walking on walkers, but these are fragile people who were in the community, they did better than people who didn't have any fragility themselves. And the way I think of that is if you're frail, your vasculature is probably frail, and you're much more, is much more vulnerable. Your vasculature is much more vulnerable, and you're more likely to have an event. And so treating it would prevent that event. So it's something that was missed in the analysis of that study. Makes quite interesting reading about that. Okay, so in terms of initial treatment, the things we need to do is we need to know the absolute risk of a CVD event. We need to know about lifestyle, and we need to do something about smoking. Now, if you've got somebody who is a current smoker or ever been a smoker, you must ask them, how are they doing with their smoking? If you, as a health professional, if you don't do that on every occasion, you'll become one of those health professionals who never asked about it. And that stopping somebody smoking in time will reduce their risk by about a half. Becoming an ex-smoker risks it by about a quarter fairly quickly, and over time that drops down to a half. Okay, so I'm just going to show you a patient here. And everything with this man is harming his health. He smokes 10 a day, his BMI is 29, his blood pressure is 175 on 90, he's drinking a bottle of wine per night. And you might want to ask him why he's drinking so much alcohol. I would suggest this man is self-medicating, he's feeling distressed about something, he's unhappy with something about himself or his life, and he's trying to, it's what we would call an acceptance and commitment therapy, avoidance. So the alcohol, heavy drinking is all about avoidance. It may be a new thing he's doing, he's got a recent stress, or it's a regular thing. He's not exercising, that's bad for him. He's got a stressful job, he fears redundancy, that's stressful. He likes pizzas, he buys 3 a week from the supermarket. The key thing, and this will be, pizzas are loaded with sodium. The take-home message is if somebody else provides you with food, unless they are deliberately making a low-salt meal, it'll have lots of sodium in it. He eats cornflakes for breakfast, and you'll know that cornflakes have more sodium in them than potato chips. He eats large amounts of hard licorice, the Dutch stuff. If you eat 100 grams of that a day, that raises your blood pressure. He takes brufen, ibuprofen, 1,600 milligrams a day for knee pain. It's wonderful for his knee pain, but it might be messing with his, and he tells you he's not keen on drugs. He likes to do things naturally. So, and I guess my take on that, if he wants to take something like slippery elm, which is an over-the-counter natural product, my view on that is I would say the problem with slippery elm, we've got no randomized trial evidence that it's effective. There are no trials to show that it's safe, and I wouldn't spend too much money on it because it may be doing nothing for you. As you know, about 40% of patients will use alternative remedies, and that's fine. They are generally partially informed about it. The key answer to a naturopath, I just wrote an article about naturopathy and COVID-19, and I said the key question to ask people is, are there any randomized trials on this treatment? And usually the answer with the natural therapies is none. I don't have a great objection to them, other than they're probably ineffective. And some of the stuff coming in from overseas can make people feel better, and it may be laced with prednisone, which you can imagine will make you feel better in the short term, but damage your immune system and your metabolic system in the long run. Okay, so we'll come back to this guy later on. So in terms of lifestyle, as you all know, it's really easy to lose weight, but it's really hard to maintain that loss. I often, when I talk mainly to GPs, but in future it'll be to nurses and nurse prescribers and practitioners, I'll ask a group of 100 primary care health professionals, how many of you got a patient to lose 5 or 10 kilograms and keep it off for 5 or 10 years? One person puts their hand up. So that gives you an idea of what you're up against. As Rod Jackson would say, there's too much cheap, yummy food in our society. And once we put on weight, our set point changes. And if you try and lose weight, your homeostasis comes in and tries and brings it back to where it was. In terms of exercise, you want to get people to exercise and get them walking unless they're young. Walking is the safest and best thing, so 30 to 40 minutes, 3 times a week. 5 times a week is even better for lowering blood pressure. If you stop for 2 weeks, it wears off. It's like physical fitness. When you stop exercising, you lose that fitness in about 2 weeks. Alcohol, men up to 3 a day, not more than 7 drinks at one sitting. Women 2 a day. We don't know what the issues are about stress, and we don't know whether meditation is consistently good. In terms of things people might be eating, licorice, corticosteroids, non-steroidal anti-inflammatories, and Sudamol. So people should only be taking Sudamol when they get a cough or a cold. It's a very good decongestant and much better to prescribe than antibiotics for colds, because antibiotics don't work and Sudamol does. But it is a controlled drug. But with the new e-prescribing system, you can prescribe it without having to treat it, to go through the whole controlled drugs, because that controls the output of it. Okay, so in terms of lifestyle changes, as I say, most of you will be eating 150 millimoles a day. You need to get down below 100 millimoles a day. The average New Zealander eats that's about 6 grams of sodium a day. The average American loses 10 grams, eats about 10 grams of sodium a day, a very high sodium. And of course, the more sodium you eat, the more fat you can eat, and the fatter you will get. To get a low sodium diet, you have to watch your bread intake. Bread contains a rather large amount of sodium. If you make your own bread, you can make low sodium bread. It has to be wholemeal, and it's hard for the bread to stay together if you don't have sodium. And then there's weight loss. That's the other thing you can do. We've talked about that. The advantage of weight loss, of course, if you lose 10 kilograms, it stays off 24 hours, and it's a long-term solution. Okay, so there we go. So exercise, reduce alcohol, and then if you're going to do drug therapy, we now advocate polypharmacy. So multiple medicines at low to medium doses. This is because when you give an antihypertensive, most of the 75% of the blood pressure reduction is in the first dose. If you double the dose, you maybe get another 15–20%. So you're getting less bang for your buck as you go to a higher dose, but you're getting more side effects. And my feeling is if somebody's truly got hypertension, they need more than one drug. If you see somebody who's on a single antihypertensive, seriously consider, do they need it? And maybe you could wean them off that. So you need to warn people, and it's usually treatment for life unless they can make a, So walking hard, walking briskly so that you're having a little bit of trouble talking. So that's moderate exercise. 3 to 5 times a week, yep. As I say, young people may want to run, and that's fine. Be careful about getting older people to run because they'll start injuring themselves. When exercise used to be one of my research areas, I was always being phoned up by businesses saying, we want to make our staff more efficient. Can we get them fit? And I said, I don't think that's a good idea because they're likely to go out and start doing vigorous exercise, and they'll all be off work at physiotherapists getting themselves fixed. Okay, yeah, so young people, okay to jog and run and do intense exercise, but the safest exercise is walking. It's pretty hard to injure yourself walking, although you can, of course. Okay, so in terms of the easiest to hard, drug therapy is the easiest. Exercise is number 2. Smoking cessation can be high, smoking doesn't increase blood pressure, but it does increase cardiovascular risk. I just mentioned it there. So why does alcohol increase blood pressure? It's thought that when you drink alcohol, your blood pressure relaxes, and then as the alcohol comes out of your system, you go through a low-level withdrawal state, and that causes a pressor effect and increases your adrenaline. I don't know how well that's been studied, but that's been the, when I was doing my PhD, that was the way I understood it. So low alcohol beer, which doesn't taste very nice, I have to say. So just limiting the amount you drink yeah, so you do get, even if you're not a big drinker, you do get a withdrawal, probably a low level withdrawal thing. And that's causing problems. In terms of diet, the DASH diet, which is a sort of Mediterranean type diet. When it comes to sodium reduction, you want to do this on a population basis. So given that we're in this phase of wonderful public health direction, what they did in the UK was all the bread makers agreed to drop the sodium in their bread. Didn't tell anybody, nobody noticed. But of course, if you're a company that drops the sodium in your bread's not going to taste as nice, you're not going to sell as much. Alcohol, what we should be doing, what they did in Glasgow, because there's a lot of violence in Glasgow, they made the RTDs expensive and hard to get, and arrested anybody carrying a knife, and they found that the violence rates went down considerably. Alcohol is pretty cheap in our society, and if you put the price up, you do reduce it. It's like tobacco. I used to be the chairman of ASH, and every time the taxes went up on tobacco, there was a 2% drop. How does the hypokalemia of licorice cause hypertension? I don't know whether, I'm not sure if it is hypokalemia. There is a steroid, there is some chemical in licorice that is a steroid-like drug which causes the blood pressure to go up. But if you just have the odd little bit of licorice, that's fine. But if you're a heavy-duty licorice eater and you've got, I don't know, I've never come across a patient eating 100 grams a day, but the hard stuff's actually got sodium in it as well. So, and there I say, so population base for alcohol, yeah, that's right, we've got Hannah there. Yeah, you're correct, I think that's right. It's an aldosterone-like, and that causes sodium retention. This is where the audience is educating the teacher, so that's great. That's why I do teaching. Okay, so that's good. Keep the questions coming. So this is out of the Lancet. This is comparing smoking to weight gain. So there's two things I could do to increase my cardiovascular risk. I could take up smoking, which wouldn't be very sensible, particularly at my age and stage of life, or I could put on 40 kilograms. So smoking, imagine yourself walking around with an extra 40 kilograms. That's what smoking's doing to you. That's what this graph shows here. There's a, these are smokers, these are non-smokers, and this is weight. So that's equivalent of 40 kilograms. Chips versus cornflakes. The doctors in training will know this. Which has the most sodium in it? I won't ask you because it's a trick question. The cornflakes has the most sodium in it. Weet-Bix is a lot better. Weet-Bix is made by Sanitarium. They're a Quaker company from the Quakers from Britain, and they're interested in good food. Things like puffed wheat are the best. You're probably better to put sugar on your cereal than put salt. If you eat porridge, sugar's probably safer than salt, within reason. I mean, both are okay within reason, but you know, if you've got higher blood pressure, it is something to think about. That's that stuff there. Okay, we've done that. It's not very popular, sodium restriction. That's the problem. When I did my PhD, half the people did exercise and half did sodium restriction. The exercise group baked me cakes. They loved the intervention. The sodium group complained for 6 months. They didn't like it. The problem with sodium is 80% of it comes from food. Only what you add to the table is about 15 to 20%. So if you do like salt, don't cook in it. Use low salt foods, not canned stuff, and then add a little bit of salt at the table. It takes about 6 months to get a dietary change. If you want to measure sodium, you have to do what the Yanomamo did, a 24-hour urine, or you could use an overnight urine. So you expand it out over 24 hours. Do 8 hours. That's a bit easier. It's easy to catch your urine overnight than walk around at work with a big bottle to the bathroom. And there's a thing called a salt frequency questionnaire. Okay, if you reduce down to 100 millimole a day, you can get about 5 millimoles of blood pressure. So it's not a lot. Exercise is about 5 to 10 millimoles, and they're slightly additive. Okay, so there's the dog. So what happened to him was that he went to Christchurch and got spooked by the earthquakes and started peeing everywhere. And of course, if you're blind, you don't want a dog peeing everywhere. So what I'm going to suggest now is just a little 7-minute stretch. So if we come back at 2:15, I'm going to go make a cup of coffee. I don't know if you want to say something to the troops, Gigi, or...
Okay, yeah, we could do that. They can have a 10-minute break.
Yep, we'll make it 7 minutes because we've got a lot of cases to go through.
Okay, so 7 minutes means 2:09. Bruce, that should give you time for your coffee, to make coffee and come back.
2:09, okay. See you
All
then.
right. Okay, guys, we will come back and in 2:09, 7 minutes from now. Gigi, can tasks, when will you discuss assessment 3? Jamie, I might not be able to do that today, this afternoon, but I promise you I will put out tutorials by next week, okay? Because we've got other guests joining us today. Is that all right, Jamie? Yeah, it's a separate tutorial. Thanks.
Well, also those ones, they say about them coming in from overseas. Yeah, so that's why I understand they're coming in now. I'm just at my half-time break for my talk.
Oh, hi, Bruce. That's more my students who are asking me questions about their assignment. So they're just a bit anxious about their assignment 3. So I might need some time. I muted you.
So do you want to finish early to do that, or
No,
stop?
no. You finish up to 3. I'm just trying to, I think they just want a bit of a rundown. I thought I'd do
Okay.
a tutorial another day, but maybe if they're staying until 3 after your lecture, then we could do that. So all the 785, if you stay after Bruce's lecture, and you're wanting to know about the requirements of assignment 3 to leading to 4, we will do that then. Thanks, Bruce.
Okay, we've got everybody back by the look. So
Yep, we're ready to go again, whenever you are.
actually, one of the things I've just invested in is that software program Grammarly.com.
Okay.
It's done wonders for my, I mean, I've got a reasonable grasp of grammar, but I'm amazed how much I've learned. And it's not that expensive. It's about $10, $15 a month, maybe
What
more.
is the name, Bruce?
Grammarly.com. You'll see lots of adverts for it.
Oh, Grammarly. Yes. Yeah. And it helps you with your grammar, spelling, and everything.
Yeah, no, I found it very good. So to improve my writing. So how are we doing here? 1409. Okay, so
Yeah,
let's. Okay, so I hope you all had a stretch.
Yeah, they've all had a
Appreciated the break. Okay, so here we go. The New Zealand guidelines differ from other guidelines, but in a sense, we agree with the European guidelines that ACEs or ARBs, and that should be ACEs or ARBs, or diuretics, thiazide type or thiazide-like, and there's a subcategory there, and calcium channel blockers, they then recommend spironolactone and then beta blockers. We would probably go beta blockers and spironolactone. Spironolactone is a brilliant drug for lowering blood pressure, but the monkey gets on your back because the potassium will go up. And there is nothing more scary than having somebody on spironolactone and their potassium starts to come up. And then you test it and it comes down a bit, and you test it again and it goes back up again. And I always say to my students, in medicine, you've got to get the monkey off your back. Like, don't get yourself in a situation where you're having to worry about things. And hyperkalemia kills. When spironolactone was made a third-line treatment for congestive heart failure in Toronto in Canada, they had a spate of deaths from hyperkalemia because patients were getting to. So we'd probably use a beta blocker. The other thing is younger patients don't like spironolactone. It has a lot of GI side effects. And then there's alpha blockers. I would avoid alpha blockers. I think at that point you might want to get a secondary care assessment. The patients probably need their renal arteries scanned and check for aldosterone and a few other little things. So, so these 3 drugs, ACE and ARBs, diuretics and calcium channel blockers, are equivalent first line. The NICE guidelines say if you're African American, you do this, and if you're not, you do that. It's all based on blood pressure lowering rather than cardiovascular outcomes. And I think our guidelines are much clearer. So just stick with the New Zealand guidelines. Okay, the targets for blood pressure are falling. It's currently, the target is 130/80. As I said before, if you go down in high-risk people, so these are people who've usually had an event, drop it down to 120/80 or close as. In the sprint trial, they're able to get it down to 123. However, 30% of patients required 3 drugs. Okay. Okay, so here's a patient I saw some time ago. It was September I saw, this was last year. Her blood pressure earlier in the year had been 136/74, but I looked back and it had been 172/80. HbA1c was 43. Now, in a 69-year-old European woman with an HbA1c of 43, she's not going to become diabetic. Sure, her pancreas is showing signs of styes, but if this was a 35-year-old Pacific Island man, I would be quite concerned about an HbA1c of 43 because it's likely to take off and get away on you. Her total cholesterol is 4.3, HDL 1.7, which is pretty good for a New Zealand cholesterol. And she's been taking a non-steroidal anti-inflammatory for 30 years. No, 30 years since, well, she's been taking it since 2011, not quite 30 years, 750 milligrams of naproxen. When I saw her blood pressure was 190 on 108. So I had a little panic attack when I saw this because this lady has probably had ongoing hypertension. And it's one of the reasons I like electronic blood pressure machines, because I think as humans, we sometimes miss blood pressures. And by the way, take home measure. When you measure a blood pressure, feel the systolic pressure at the radial artery. So put the cuff on, feel the radial artery and pump it up and find out when it disappears. Because if you just use your hearing and you don't palpate the loss of pulse at a high, when the cuff goes high, you will miss. We had a student in our clinic say a patient's blood pressure was 120/80. It was actually 180 over 80. And that's because of a thing called the auscultatory gap. It doesn't seem to get taught, as we had it drummed into us. And it's actually interesting, the medical registrars sitting there, part one, most of them don't do it. So if you want to be a good clinician, palpate the artery, pump the thing, unless you've got a whole lot of blood pressures. But this late blood pressure is jumping around. And that's where I like electronic machines, because who got the 136/74? Were they listening properly? Which is the true one out of those? And I find one of the advantages of the electronic machines is occasionally you get a goofy result, but by and large, they're fairly consistent. And if I get a high blood pressure, I always cross-check it with an electronic one, because I haven't got that much confidence in my ears. And we self-deceive a bit as clinicians. Okay, so this is her risk of CVD. So it's not actually that high. This is based on the Canadian website where you can find the New Zealand CVD risk, Rod Jackson's Predict. So her, oops, hang on, oops, sorry folks. Her risk is 7% roughly in the next 5 years. So even with a blood pressure like she's got, and if you treat her, but I was pretty concerned. I wanted her to stop her non-steroidal anti-inflammatories, and she was very unhappy with that. She was not pleased at all. She told me so. We had quite a nice discussion about it. So the numbers needed to treat here are 50. So 2 people will get a benefit. So this is 100 people like her. Now, how do you fully inform somebody about the benefits they're getting from treating their blood pressure? I think you have to show them this, because and occasionally a patient will say, well, do you think I should take the medication? In which case I would say, well, our guidelines would suggest you do. Technically, the numbers needed to treat here are 50, but she's probably closer to the high end rather than the low end of that. So I think this is a terrific way to explain people, because I remember a Maori man in his mid-50s saying to me, should I take a statin? Should he take a statin? And I thought, I can't make that decision for you. I don't know what your values are. How do you feel about taking a pill every day for the rest of your life? I showed him this, and the NNT was like 50, and he said, forget it. And I thought, wow. Because the problem is we as health professionals are very risk averse. I would probably happily take a statin at that level, but I've got patients who would think I was crazy. You know, why take it? So that's 100 people who, like her, take a statin. 2 will have an event, 2 will get benefit, and 5 won't. So most people don't benefit from most drugs. Clearly down here we've got 5 people still having an event, but there's the other 93 people who aren't getting a benefit, and they're all taking those pills. And remember, statins are one of the best, and blood pressure medications are some of the best we've got. So I'm sorry to burst your bubble, but we're trying to be rational in our prescribing.
I think, Bruce, there's a question there about what did you suggest instead of non-steroidals?
I just suggested she stop or use them occasionally. She was taking them for generalized body ache, which is a bit trickier. If someone's got knee pain, they could use topical NSAIDs. You see, what I couldn't figure out was why this woman had a normal blood pressure a few months ago. It may have been a misreading, and she's been taking a steady diet of non-steroidals, and you wonder what they're doing to her kidneys. Blood test for her kidneys was okay. EGFR was 56. We did an albumin creatinine ratio, that was okay. I got her back and the blood pressure was 180 on 86. So I said, I thought we better start treating this, ma'am. And she wasn't too thrilled with that either, but she took my advice, which was fine. You know, if she'd said no, I would have said, okay, well, you might be one of the 93 who don't benefit. Of course, most people are not going to get benefit from treatment. And now that I've been around a long time, I've seen patients that I fussed over their blood pressure for 30 years. And one particular patient died of ovarian cancer. And I sort of think, all those years, she lived to 87, all those years of fluffing around with her blood pressure and diabetes, and it's not what she died from. So one of the advantages of having been in the game a long time is that you get a bit of perspective on these things. I mean, these blood pressures, those of you who are new to the field might be sort of slightly terrified by them. But once you've seen many people like this not come to a great deal of harm, don't take their medication, etc. Okay, so in terms of starting, first choice would be an ACE or an ARB. And as I say, I like the combinations. For thiazides, there are the thiazide type, which is bendrofluozide, and thiazide-like, which is chlorthalidone or indapamide. And these two are the ones with the most evidence. This is still used by, this is the most commonly prescribed thiazide diuretic in the country. More than 85% of people get that, but it's nowhere, the evidence would suggest this on its own is nowhere near as effective as this, okay? For calcium channel blockers, we either use felodipine or amlodipine. For ACEs or ARBs, the ARBs, if I'm using an ARB on its own, I'll use candesartan because it's long acting. If I'm using the combination, I use losartan because it has the hydrochlorothiazide with it, and I find that gets big reductions in terms of blood pressure. Just coming back to the non-steroidal questions, there aren't a lot of good alternatives. If you've got osteoarthritis of the knees, then taking non-steroidals makes you feel brilliant. We really have a very poor choice of painkillers because Panadol won't wear it for that. Okay, so this is what we gave this lady, which is an angiotensin receptor blocker. Not quite, it'd be nice if this was candesartan with that, and there are combinations available overseas, but you can double the dose of this if it's not helping, because that'll give you a longer blood level plus increase. It's a fairly low dose of hydrochlorothiazide. You can't get hydrochlorothiazide here on its own. Okay, so now we need to do a blood test. We've started an ACE or an ARB. We have to do a blood test within, say, like a month later to check for renal artery stenosis. What blood test would that be? Can I have a few answers? So it's mandatory to check that, along with electrolytes too. Anyone want to answer that one? What blood test would you do after starting an ACE or an ARB?
Renal function?
Yep, renal function. Top marks. You pass with flying colours.
No.
Pass your name on to Gigi. So her creatinine went up from 90 to 102. So does she have renal artery stenosis? And if she does, this isn't the young woman's renal artery stenosis where you've got fibromuscular renal artery. This will be an atherosclerotic renal artery. Does anybody know how much you're allowed for your creatinine to rise?
30%, up to 30%. If it's creatinine rise more than 30%, so we need to.
Yep, that's right. It was quite funny. I remember asking one of the renal physicians this, and he said, "I'll go and look up to date." I thought, oh, okay. So look, that's about right, about 25, 30%. Having said that, you still want to watch it. I had a man who was a vasculopath, and he came in and his creatinine went up 20%. So I left him on his ACE inhibitor then. And then it went up to 25%, then 30%, and then 40%, and then 15%, 50%. And I thought I'd wreck this guy's kidneys. And then about over the next year, it came down again. And I was so relieved that this guy, I hadn't wrecked his kidneys completely. So her blood pressure was 165 on 80. So should we double the dose or add? Well, following my advice before, yes, I have heard that Silazapul's running out and won't be available. That's Silazapul plus. Silazapul alone will be available.
Oh, okay.
Is that an error due to 5.5? Sorry, is that 0.5 or what are you referring to, the 0.5 or 5 milligram there? Alejandro, could you just expand on your question? What are you referring to there?
Somebody said that somebody committed an error, like instead of giving 0.5, which the doctor prescribed, I think
Yep.
gave 5 milligrams.
Easy to do, isn't it?
Yeah, and then that's what I've heard previously. And then they said because of that, they're asking us to give lisinopril now in the hospital and not prescribe Silazapul.
That's good. Yeah, okay, that's a good question. So lisinopril is a longer acting ACE. The other one is perindopril. Ramipril would be nice to have here, but it's not available. What would you recommend for a pregnant woman? They tend to use the calcium channel blockers or beta blockers for high blood pressure in pregnancy. ACE inhibitors and ARBs are not good. Entresto is for heart failure, not for blood pressure, and it contains an angiotensin receptor blocker and another drug called a nephrolysin inhibitor, which works on a different pathway. So just answering the questions. Can you all see the questions? Everyone can see those questions? Could somebody answer yes?
Yes, I think I can, Bruce.
Okay, good. Okay. Rightio, back to our man. So just looking at that horror show list. Now this is pretty unusual, but I have seen patients. This guy is a train wreck. This guy is a train wreck. And you wonder why he's drinking a bottle of wine a night. Is this new? Just remember that when people get stressed, they increase their alcohol intake. Because I remember we had a counsellor in our clinic and she was reporting enormous amounts of alcohol. I go back and look at these patients' notes and they'd be a social drinker. Well, of course, what the human response to stress is to increase their alcohol intake. Look at the run on the bottle stores before shutdown. We're all a little bit addicted to our alcohol. Okay, so what would you, what's the most important thing to deal with first there out of all those things? Should we get him to lose weight? Should we cut down his alcohol, get him exercising, doing mindfulness?
His stress.
Okay, so we've got somebody saying stress, but we've got 3 saying smoking. I'm with the smokers because you'll reduce his risk by 25% very quickly and 50% long term. Okay, you only have to get 2 smokers to stop and you've saved somebody's life. There's nothing else in healthcare that will do that in general.
You say that he's a train wreck, which I totally agree. But when you look at all of the evidence that you've got here it's pretty much lifestyle, isn't it? If you had a good chat to him about reducing how much alcohol he drinks, his smoking, stay away from the pizzas. Flick your cornflakes out to a Wheat Bix or something else.
Yeah.
Try finding something. I mean, it's you know, and the alternative is he's not keen on drugs, and you say to him, well, if you make these choices, then changes, then you're less likely to have to take a drug. So,
Yeah.
I mean, these are all things that he could do himself, which he takes some.
Absolutely.
Yeah, I mean, it's different, I guess. I reckon it's just as hard if they come and they've got really high blood pressure, but they don't admit to having any of these other issues going on. So
No, this guy's got problems, hasn't he? And his drug of choice is probably alcohol. It's interesting how people don't want to take pharmaceutical drugs, but they'll take recreational drugs like alcohol. So yeah, explore what can be reduced first. That would be one thing. We'll say, look, you know, you've got a bit of a royal flush. He's actually got 2 royal flushes here. If any of you are poker players, like he's got, I think 10 at least. You could ask him what he'd be willing. What would you like to change first? Yeah, it might be mental health issues. There could be a whole lot of things here. But in terms of the point I'm trying to make here, in terms of lifestyle, it's not so much his blood pressure we're worried about here, it's his cardiovascular risk. And the quickest way to get his CV, because we fuss around blood pressure, but actually it's total risk that counts. And this man's risk, I'm going to show you now the tables. Okay. Oops, hang on. We seem to have lost things there. Okay, so hopefully you can see that. So his GGT is up. So what are the causes in why his GGT may be up? And his ALT's at the high end of normal.
Is alcohol use?
Yep, could be alcohol use per
Could be
se.
liver.
What's the other thing? What's the other common thing in our community?
Oh, P.
Lots of it.
Yeah.
Fatty liver?
Fatty liver, yeah. So it could be fatty liver. You've got to be very careful just seeing an elevated GGT and saying, you know, you're drinking too much. And the guy says, well, I don't drink and I've never drunk. You suddenly look like a bit of an accuser. So yeah, good, well done. 2 reasons, alcohol, fatty liver. You might want to check for hepatitis A and C. However, by the time you're 63 years old, most 63-year-olds in New Zealand will have had hepatitis A. I discovered this when my family and I were going to Africa, and we were about to pay for a hepatitis A injection for my wife and I, and we were both tested for hepatitis A, and both of us had antibodies. This was in the days when it didn't cost a fortune to get an antibody test. And neither of us had had jaundice. We'd obviously had asymptomatic hepatitis A. You might want to check somebody for hep C, because we've got these wonderful Mavorite treatments now where you can, with oral tablets in general practice, get rid of hepatitis C. And we're missing a whole lot of people. If you had any idea this man may have had blood transfusions before 1992, or he'd used intravenous drugs, that's a tricky discussion. He might have a very high-powered, fancy job and doesn't want to admit to you that he took a bit of heroin when he was at university as a party trick, and shared needles, of course. So, yeah. Okay, so where to start? So smoking's the big
Bruce,
risk.
you should also be checking for hepatitis B as well, because that they can also be shown up in the liver, as hepatitis C and B should be checked at the same time if you're going to go down that.
Yeah, that would be a fairly easy thing. There's a bit of an age thing there. This guy would be too old to have got hepatitis B vaccination. They started here about 1986. So anybody in there older than 40 probably hasn't had it. So you might want to check B. But, you know, hepatitis B really makes you very sick. It would be unlikely you'd be walking around with that. So this is the, when you go to this calculator, it shows you the smiling faces. Click predict, which is Rod Jackson's one. It's over to the right-hand side. If you do Framingham, you'll get the old risk. So somebody like me has a 12% 5-year risk on Framingham. I have a 5% risk on predict. So it roughly halves your risk, the new risk equation. So this is this man in the next 5 years. That's his CVD risk, 15.6%. Now, if he were to stop smoking, his risk would now be 10.5%. And if he added exercise, it would go down from 10.5. So 2 people out of 100 would benefit, would go down to 7. Oops, hang on, we're just doing the same problem as before, sorry. And if you went on to a low, I can't add these things, you can only do them individually. A Mediterranean risk diet would take him down to 7%. So there'd be a whole lot of, as the person who said about lifestyle risk said, yeah, there's a whole lot of stuff you can do there. And if you get this guy to lose 5 kilograms, he may not need blood pressure medication at all. So he's happy to take aspirin. Well, this is using Vanessa Selak's. When his blood pressure is 175 on 90, 6 people out of 1,000 would have a harm, 17 people would benefit. So the numbers need to treat here, that's still an NNT of about 50 to prevent an event, but an NNT of about 200 to get a harm. So you can see how you can negotiate. You can say to the patient, well, 17 people out of 1,000 will get a benefit, but 6 will have a major bleed. And these aren't cerebral bleeds, these are usually GI bleeds. If these were cerebral bleeds, it would be a whole different ballpark. And this is if his blood pressure is 130/80 and he's not smoking, and his HDL to cholesterol to HDL ratio, 4 would be avoided and he'd only get 6. So this is the problem with primary prevention. It's pretty feeble compared to the harms. So NNT of about, what would that be, 6.6 over 100 to get somebody better, and then you've got this risk of bleed. So that's why primary prevention, whereas with secondary prevention, it's slam dunk. You get a complete benefit. The benefit over here is huge, and the risk stays the same because the risk doesn't go up. The harms stay the same, but the benefits change depending on the baseline risk. Take home message there. Okay, here's another lady. Okay, so this is a lady I've known for years. She's a very unusual woman. She's quite reclusive. She's been taking 0.5 milligram of, we inherited her from another doctor. And when she arrived, this was her blood pressure. She'd been taking Ativan for years, and she turns up regularly to get her Ativan, but she doesn't want her blood pressure changed. Okay, these are her, she's on bendrofluozide and atenolol. So is atenolol a good medication to be taking? Do we give atenolol these days? Does anybody know why it's gone out of fashion? I've sort of got it there. Okay, so it lowers peripheral blood pressure, but they think it's not effective because it doesn't lower central blood pressure. And of course, you want your coronary, if you want your arteries relaxed, you want your coronary arteries relaxed. So, yeah. So this lady really has systolic hypertension, doesn't she? Her systolic's up and her diastolic's below 80. So that's called systolic hypertension. And you'll only see it in these older, usually female patients who haven't been well cared for. They've literally got hardened arteries, so their blood pressure, is up. They have their huge CVD risk, and you can lower their blood pressure. I was always taught you couldn't lower their blood pressure. So she has systolic hypertension. So this is her, oops. This is her, so numbers need to treat a 33 for her. So that's, so even with all that risk, she's not, that high blood pressure, it's not a massive, it's not a slam dunk, but you can see it's worth treating from our point of view. Now, the good news about her was she had to have an eye operation. And I said, they're not going to do the eye operation with your blood pressure like that. They're going to send you back to me. So eventually, I put her on the low sartan high chlorothiazide, and her blood pressure came down to that. I switched the atenolol for bisoprolol, and then that's what happened there. And then I added felodipine, so a third drug. So she's got an ARB, a very low dose diuretic, and a calcium channel blocker. She's on triple therapy, and then she got her eye surgery done. Fortunately, it was delayed a little while. She probably shouldn't have been driving. Her vision was so bad. So after years of not being able to stop her atenolol or her bendrofluozide, I was able to get her onto some modern medication. Okay, so here's the man, he's 79, and in 2017, he had a middle cerebral artery stroke, and he was given thrombolysis. Now, one of the wonderful things, now I hope you've all heard about this, is I'm not sure what sort of stroke it is, but with some of the strokes, they nowadays stick a catheter up your groin and pull the clot out of your brain. So if and when you retire, or if and when your parents retire, tell them to live close to a big city, because you've got about 4 to 6 hours to get these clots pulled out. And if you go and live in the Hokianga, you're probably not going to be able to get into Auckland Hospital. All the major hospitals are doing it now. So it's dramatic. They had a 30-year-old guy at Waitemata, had a massive stroke. They pulled the clot out of his brain, and he was back at work 3 weeks later, completely normal. I mean, thrombolysis helps. Thrombolysis gives about a 15–20% of benefit. These things give like an 80 to 90% benefit. So he was put on atorvastatin 40 milligrams and clopidogrel 75 milligrams. And when he came in, his blood pressure was 168/88. So what is his risk? Does anybody want to say? Is it above 15% or below, just based on the fact that he's had an event? So is he
I would say that it would probably be above 15%. He'd be at high risk.
Yeah, he's high risk, isn't he? By the fact that he's had an event. Yeah. So he needs the works, basically. And he's sort of got the works, except for his blood pressure. So this man is getting what we call secondary prevention. So this is when the aspirin or the antiplatelet agents work particularly much better than in primary prevention. And remember, one of the rules in healthcare, whenever you get something, you're more likely to get more of it, whether it be cancer, whether it be cardiac, whether it be stroke or heart attack. You had one stroke, you're more likely to get a stroke. So this guy's in tiger country. So I saw him, I had a mini panic attack and started getting him on, he wasn't on dual platelet therapy. And the problem with dual platelet therapy, there are benefits, but you increase the harm. So it becomes a little bit tricky. Well, someone's just put up my reference, evidence-based first consultation for depression, 9 key messages, British Journal General Practice. That's well worth reading. I can flick a copy out to you if you want when we send out the email.
Please, Bruce. Yeah.
Evidence-based, and I've got a YouTube on it too, a 25-minute YouTube, and the YouTube. I now know how to make YouTube as a result of the lockdown. So why did you put that up, Darshan? Why was that? What was the reason for putting the reference up? Nice that you should quote me, but okay, we'll carry on waiting for that. Okay. So you can see my signature is low sartan hydrochlorothiazide. I really like chlorthalidone. And occasionally I add chlorthalidone to this because it looks a bit goofy because you're giving 2 thiazides. But the nice thing about why chlorthalidone is probably such an effective antihypertensive. If I was on a desert island, it's probably the medication I would take with me. Probably some non-steroidal anti-inflammatories for pain as well, and a few antibiotics. But it's long-acting, and it probably gets that notch at nighttime. That's probably one of the reasons why it works. And in the sprint trial, the Americans have finally realized that hydrochlorothiazide on its own is a pretty useless diuretic, and that you need chlorthalidone. So in the sprint trial, they use chlorthalidone. They've come to their senses. The Americans have some very odd ideas about hypertension. Some years ago, they raised the threshold for older people, completely against the epidemiological evidence. Have since come back and changed that. I couldn't believe it when they did that. Fortunately, we've got epidemiologists like Rod Jackson driving the Heart Foundation here. Okay, so let's just, sorry, we just jumped a couple there. Okay, his creatinine was okay, but his blood pressure was 152 on 85. So what did I do next? I added spironolactone, which was a little bit unusual for me. I don't know whether he'd had trouble with calcium channel blockers, but I was a bit, it was looking like we were going to have trouble with this man. Oh yeah, so the answer to the evidence base for the first consultation, yeah, you've got to look at people's avoidance when they're drinking a lot of alcohol. The other thing is Peter Adams in the School of Medicine talks about people who have substance abuse disorders like an alcohol use disorder, is they actually have a relationship with their substance. Their substance becomes like a lover, and people don't want to give up their lover. And that's, if you think of substances as being like a lover, you don't want to give them up. You can see why it's so hard to change the behavior in somebody. You wonder why they keep going back and drinking a bottle or two a day. Okay, so what do we need to check in this man's blood? What blood test do we need to do? Within a few days of starting this, usually 3 days, 3 weeks, and 3 months. That's what they do in the study. Potassium, top of the class, they're all passing. They were all normal. His albumin to creatinine ratio was normal, and his last BP was 120/70. He was feeling good. I was feeling good. Okay, so probably wouldn't do his liver function, although it wouldn't be unreasonable to do in him. You might find out a few surprises. I don't think he's a heavy drinker. Okay, so take home message. In terms of history, we need family history, because family history of CVD events increases your CVD risk. You might want to ask a bit about dietary stuff, like licorice, and any medications they may be taking, like Sudamol or non-steroidals. In terms of examination, weight, height, blood pressure, pulse, check the heart. You might find that you might find something odd there. Respiratory, if they had basal Krebs, you'd worry about heart failure. And radiofemoral delay, as I say, explain to patients why you're putting your hand in their groin. Labs, they're rarely helpful in primary care, but you do them. You do them. Most of it's due to what we call essential hypertension, so we find no cause. CVD, do the risk on the Canadian table. And lifestyle, smoking always. Exercise is a popular one. Weight loss, you may be an enthusiastic weight loss. Bariatric surgery works for about 50 or 60% of people. It doesn't work for everybody. Recently, there was a study done in Glasgow called the DIRECT study, and there's an endocrinologist at Waitemata called Carl Peters who was on it. Some of you may have met him. And they lost 10 to 12 kilograms. This was newly diagnosed diabetes. And they put them on an 800 calorie diet a day. If you really want to lose weight, go on an 800 calorie diet a day. It's 3 sachets of Optifast plus a cup full of vegetables to keep your bowels going. They lost 12 kilograms in 3 months, and 49% of them lost their diabetes completely. In fact, when you go on such a crash diet, you have to stop your blood pressure medication and your diabetes medication. Otherwise, you'll keel over with hypotension and hypoglycemia. And they may be setting up clinics in Auckland to do that for people who don't want to do bariatric surgery or people who can't get bariatric surgery. Okay, sodium restriction, something that enthusiasts may take. People don't like doing it, so it's usually something I don't bother with. If they're willing to cook low salt bread, there used to be a shop out towards St Heliers that sold low salt bread. I don't know if it still does. That's going back a long time. Medications, if the 5-year risk is greater than 15%, and remember in primary care, you negotiate. You don't say to people, you must take the medication. That'll get you in front of the HDC. So negotiate, be the nice guy. I just say to patients, look, I'm merely your advisor. You know, I can advise you what to do. It's up to you to make the decision. It's your life. Or if the blood pressure is greater than 160 over 100, or 140 over 90 if CVD risk is greater than 15%. And based on that, you'd probably drive that 140/90 down to 130/80. So, and I think that at what rate is it healthy to lose weight? Well, about half a kilogram a week would be quite healthy if you can. These people would have been losing around about that, maybe that. Yeah, it's a randomized trial, Gigi, randomized trial from Glasgow. These are people within 6 years of having diabetes, which means that when you get diabetes, you've only got half your pancreas left. Okay, so that's the end. So are there any more questions? We can take questions for the next 10 minutes, unless Gigi wants to talk to you about your assignments.
No, it's okay, Bruce. No, this is interesting. I think this is the most interesting part, having both postgraduate nurses and medical students, I suppose, the questions that they're asking. I was just responding to, not necessarily to the evidence based in terms of Taylor's one, but I think they were saying that with losing so much weight, did they get gallstones? And I said, well, was there any evidence around that outcome that they will get?
Well, they did look at that. I think there are a couple of people got gallstones in the intervention group and one in the control group. It was pretty low. Yeah, but that is a potential risk of losing weight too quickly. You can go thumbing. No, they didn't all get gallstones. Very few of them did.
No, I'm not saying they all did, but I actually know of a couple of friends that did this. They weren't diabetics, but they did that OptiFast thing, and they both ended up in ED with gallstones.
Oh, really?
And the ED consultant said to them that there was some correlation between the OptiFast and gallstones. So yeah, they were actually quite sick with it. Yeah, had to go to theatre and everything. So yeah. Just a thought.
Why do I did not get why an ACE is important to prescribe first in a beta blocker. You get the most benefit from the ACEs, diuretics, and calcium channel blocker, less cardiovascular benefit from beta blockers. So they've sort of slightly gone out of fashion. They were when I started practicing, they were sort of flavor of the month, but they've sort of gone off their perch. They still are effective, and they're a lot easier to use than spironolactone. Yes, someone says cholelithiasis is a known complication of bariatric surgery. Yeah, any more questions there?
Bruce, there was just one thing in my mind when you were talking about this as genetic susceptibility. Like there were lots of genomic predisposition, but what is your opinion about genetic susceptibility? I mean, it probably goes back to Joanna's question as well, as to, because of genetic susceptibility, there could be some side effects like gallstones, you know, for someone who...
Well, what they're doing, a colleague of mine in Vancouver, primary care academic, is looking at the genomes of people to see who's going to get what. So if taking an ACE inhibitor causes gallstones, you might know that in future. Of course, the cost of genome testing is going to be hundreds of dollars. And these medicines cost, you know, a few cents. So whether it's going to be cost effective, or whether people, I mean, I guess there's some patients that say, I want to know, you're giving this to me for the rest of my life. So I think the genetic revolution sort of hasn't arrived in primary care yet. It has arrived in hematology. I had acute myeloid leukemia 10 years ago, and they looked at my genes, and my genes are okay of the tumor, and I went to chemotherapy, not bone marrow transplant. That was in 2011. I was stunned. I was stunned. So it's really, in some fields, it's really operating. ACE prevent ventricular hypertrophy. It is the one that's recommended, but I think it's, my guess, it's more about lowering blood pressure than ACEs. A lot of people will say ACEs are better than other drugs. I still think the jury's out on that, but, and the same with giving ACEs and albuminuria, but the advice is to give ACEs if you've got ventricular hypertrophy. And chlorthalidone is particularly good with hypertrophy and heart failure. It's significantly better than doxazosin as an alpha blocker. What do you offer first with smoking cessation? Position on vaping. Smoking cessation, I try and find out what people would like.
No, Bruce.
Yep. What's up? Question?
No, sorry, Bruce, that was me.
Have we finished, or what's happened?
No, you keep going. No, it was just me.
Okay.
I had an error.
Well, the smoking cessation, just plain quitting. Most people quit without any medical input at all. In New Zealand, we have to go for gum or nicotine patches or lozenges. Then you move up the scale to bupropion or nortriptyline, and then if all else fails, you can go to Champix or varenicline. The thing is, you need to, it's always important to ask people when they need their first cigarette. I was just talking to a woman the other day. She smokes 4 cigarettes a day. She doesn't need one when she wakes up in the morning. So I say to them, well, it sounds like you're not chemically addicted to smoking because you can get by without cigarettes. So a lot of people are socially addicted to cigarettes, not chemically. If you have to have one within half an hour of getting up, you're chemically addicted, and that's going to be a bit harder to give up. But someone's got to have a big reason why they want to give up. Vaping, Ash recommends vaping as a way of smoking cessation. I just had a question from a student health doctor saying, how do you get people off vaping? And I don't know quite what the answer. I put her in touch with a smoking cessation, Hayden McRoby, a smoking cessation expert who lives in New Zealand, for his opinion. So I don't know quite where they got to with that. I mean, ACE ARBs, then other groups. Yeah, probably. I think that's sort of the advice at the moment for ventricular hypertrophy. But the end of the world isn't going to happen if patients can't tolerate them. People tolerate the ARBs pretty well. I've really had nobody have problems with ARBs. And remember, people won't feel well when they start antihypertensives. It's a bit like, I think, driving a car at 100 kilometers an hour and you come to a 50 zone. You feel like you've come to a dead stop. And I often say to people, and there's another reason not to bring people's blood pressure down quickly, they will feel uncomfortable. Some people find Champix very effective, yep, but there's a criteria. You have to do a special authority, and they've got to try it in RT first.
Right, yep.
Champix blocks the nicotine receptors. It does make people feel slightly nauseous, and I had one lady, she was quite a slim little woman, and I just wondered, I dropped the dose with her, but I just dropped it down to 1 a day. But people say it just kills the desire to have a cigarette. You just have no desire, takes away that desire completely.
What
so I
age
think it's about time we finished, Gigi.
There's one last question. Do you want to answer that and then we can go on, or?
Probably 100, at what age would you not bother treating hypertension? I'd ask the patient, but probably 150.
Great.
Years old, yeah. If they wanted to be treated in 120, I'd say, well,